Welcome to BizTech's Health and Wellness Show. Today we have Dr. Joseph Saba. He's the CEO of Axios International. Axios International was founded in 1997 and is a global healthcare access organization that bridges the gap between private and public sectors through innovative programs for critical medications and medical services. Now, that sounds like a mouthful, but to tell us more, Dr. Joseph, welcome to the show.
Thank you very much. Thank you for having me. It sounds convoluted, but basically there are many innovative medicines that are coming. They are very expensive, not always reimbursed, and people need help in that. That's how the whole thing started. As I am an infectious disease physician, and I work on HIV/AIDS and joined the World Health Organization, and that's where all of this started. If you remember, with HIV/AIDS, people were dying.
Yes.
And then we discovered medication that makes them live. As long as they take the medication, they live, which transformed actually that lethal disease into a chronic disease. But the issue was, how do we get it to poor countries? How do we get it to middle-income countries even? Because at that time, it was extremely expensive. And I was tasked to do that, to negotiate with the companies, to reduce prices, to find different models, to make sure it works. When I was at the WHO and UNAIDS at that time. And this is how we founded Axios, because what I found is that the issue was not only with HIV/AIDS. There were issues with cancer. There were issues with many other medication, rare diseases that had expensive medication and needed help. And that's how we started, actually, Axios, and continued to work until now because there is an unmet need.
Now, you are particularly active in Southeast Asia. You have a global footprint, but you're particularly active in Southeast Asia. Paint a picture of your impact in Southeast Asia, particularly in markets like Malaysia and Thailand.
Oh, yes. I mean, this started, I would say, in 2007, 2008, when we started coming to Asia, where people, didn't have access, didn't have programs. And some people said, yeah, we need to just drop the prices. But when they drop the prices, is how low can you go when you have to pay $3,000 a month or $5,000 a month for medicine? So dropping the prices was not a sustainable solution for anybody. And then we started working on some donations and helping people get some free of charge, but all this needs management because you need to follow the patient. And this is where we found the first gap, is that you go to the doctor now, you get a prescription, the doctor takes care of you, and these are very good doctors, but they are very busy. And usually people even sometimes spend 3 months before they go see that doctor. And then when you take that prescription, you go to the pharmacy, and then you're on your own until you see the doctor the next month. And we don't know what's happening to the patients. We don't know if the patient needs maybe other help, different help. So working with the patient as they need follow-up was very helpful, because it helped the patient stay on treatment and improve actually their medical outcome. So that was the first finding. Beside the issue of affordability, which we could address, it was also an issue to make sure that the medicine is delivering the outcome that we would like it to have. And that was extremely successful issue. And also, initially, the doctors, I am a doctor, and say, this is my patient. I don't want you to meddle with my patient. But at the same time, when I was practicing, I would say, 25 years ago or 30 years ago, I used to spend 45 minutes with my patients. Today, the doctors can't afford that. Their waiting room is full of patients. So they cannot spend the time that is needed to educate the patients, especially when it's complicated disease, to educate these patients to really make sure that the patients understand the disease, understand the treatment, and they are able to cope with their disease, basically. So that's all these aspects worked out. Yeah.
And there are also some institutional barriers also in terms of the healthcare system. Maybe and that, unfortunately, these institutional barriers then really prevent, sometimes delay access to the latest treatments, for example. Could you give us some insights into some of these barriers, perhaps, and then how you solve that problem?
There are institutional barriers, and there are also barriers related to the healthcare system, the way it is structured, you know. So I would say the institutional barriers, like we know now, when you have a new product, it needs to be registered. And usually it's registered in the US and Europe, and then it starts being registered in the other countries, and then it takes years. It's like, why does it take years? It's the same file that people are actually submitting to the authorities. So there is no new information. So why don't we try to streamline these ones so that patients have more access to these innovative medicine? That's like one example. The other example is sometimes, you know, it takes a long time to have reimbursement, and of course there are also price negotiations. So these are institutional barriers that actually prevent the patients from getting the treatment because simply the medication is not in the country. But there are also barriers inside the healthcare system. The patients are lost in the system, you know, and we did some of the study in some of our studies, not in Malaysia, because in Malaysia you have good healthcare system, but women with breast cancer had to wait 8 months before they get diagnosed. By that time, the stage of the disease changed. Yes. You know, you can't afford that. You need to help the patient. But our hospitals are very good, very well functioning. But the hospitals wait for the patient to come. There is nothing proactive out there to encourage the patient to come or to follow up with the patients when they leave the hospital. So as long as the patient comes, it works well. If the patient doesn't come, or if they have any restriction, they have nowhere else to turn to, then it doesn't work. And these are really health system barriers that are important. And that's where we work. You know, go ahead.
And Joseph, I want to interrupt you here because
please go ahead.
For the audience to get a clearer picture, and obviously you're solving a lot of different problems. Maybe we can take a step back and you could explain to us how you are involved in the patient treatment journey from end to end. That will give us a better context of how you intervene at different points.
So we intervene when the doctor prescribes the medicine and the patient say, I can't afford it, you know? So that's where we assess the patient, we do financial assessment, we see how much help the patient needs to get, and we work with the patient. Then when the patient starts getting the medicine, we follow with the patient to make sure that the patient is taking the medicine.
Okay, can I stop you here just before that? Now, you've done a financial assessment of the patient. They can't afford it. How do you solve that problem? What are the various ways that you solve that problem?
Yes. I mean, the first one is we agree first with the pharmaceutical company that there will be patients who will not be able to afford the full course of treatment. Let's say you need one box per month. Okay, so you have 12 boxes. Well, the patient cannot afford the 12 boxes. And we don't want the patient to pay 2 boxes, run out of money, and stop the treatment. What we want is the patient to get all 12 boxes, to get the full course of treatment to maximize the medical benefit. So we agree with the company, say the patient can pay 4 boxes, you know, and then the company agrees to give them maybe 8 free of charge. I'm giving you an example. Sometimes we cannot bridge completely that gap. So we identify some other sources of funding that can help them. Sometimes the patient has an insurance. So the insurance can reimburse, let's say, 3 packs, and the patient can pay 2. Now we are 5. We have more to do. So it's like a puzzle. You see where you can get the subsidies and what the patient can afford, what the company can give, put them together to ensure that the full cycle is respected. That's what we try to do.
Okay, and so that then you have to work with various stakeholders in each country.
Oh,
you
definitely.
have to work with the government system, the pharmaceutical companies, the healthcare providers themselves,
the pharmacists,
donors.
The donors or charities. Yes. We have to work with all these stakeholders to make sure. Our focus is the patient. The patient needs to get the treatment and the full course of treatment. That's why I keep insisting on that, because there is no point. Like, imagine a patient who has cancer. You give them 2 months treatment and they stop. You wasted their money.
Yes.
Because it doesn't help. You really need to give them the full course so that everybody's happy. The patient is happy because they are better. The doctor is happy because their patients are better. We are happy because it worked. So this is our guide, actually.
So in the patient journey now, we're at the journey where you've arranged for the funding. You then start working with the patient. Walk us through the rest of the journey.
Yes. So now we follow with the patient. And what happened is, as we were working on these programs, like we had many patients in the program, all this successful. Then at some point you say, okay, well, but there are many more. Let's take breast cancer. I'm just making an example. Mm-hmm. Many more women with breast cancer. Where are they? Why aren't they in the program? So that's where you find that, well, they're still lost in the system. They haven't been diagnosed and they haven't been gotten to the stage of prescription of medicine to get into the program. So we start going and making campaigns to make sure that people know what to do, like informing the population about the program, about where they should go to get diagnosis, etc. So that's another angle about how we started looking at the gap, at the gaps. The other gap is to make sure that the patient continue the medicine. And here we found that in some of our programs where we run the program in parallel with maybe a segment of the population who is fully reimbursed.
Okay.
And we found that the people who are fully reimbursed have shorter duration of treatment than, meaning they stop their medication earlier than our patients. So that's where we said, so what's happening? Why?
Okay.
They are fully reimbursed. There is no affordability issue.
Yeah.
The issue is they are lost in the system after. There are plenty of things that make you stop your treatment. Your neighbor tells you that this is poison, you shouldn't take it. You have sometimes you're afraid of adverse event. You feel you're not, it's not working very well, and you really have a lot of side effects, so you stop. Sometimes you got much better, so you feel, I don't need the medication anymore, so I throw it out. There are plenty of these aspects that actually block the patients from getting the treatment. The doctors work a lot on these aspects, but you see the doctor 10 minutes every month. They don't have time to tell you all of these things. So we started also working in that area. So just to give you an idea about how we work through the patient journey, actually.
Now then, obviously now what's happened in the last couple of years is monitoring of this patient treatment journey has gotten a lot easier because of technology.
Yes.
How are you now doing this differently compared to, say, 10 years ago?
Definitely. And thank you for asking that question, because it's very important. And we identify it actually in 2018, before the COVID pandemic. Because of the COVID pandemic, we did realize that people realized that when the patient is outside the hospital, there is no way to reach them. And we needed to reach them for COVID to prevent them from getting infected, especially people with chronic disease who were vulnerable and to the COVID pandemic. However, in 2018, we said, okay, so now it's nice, we're following all these patients, etc., but we have new technology. So we started working on a system that where, you know, the patient is connected to us, connected to the pharmacist, connected to the physician. So everything goes through that, including, like, we still talk to the patient because you still need the human touch. And we published actually articles about that when you look at just technology without human intervention and technology with human intervention, the technology with the human intervention was much more effective and protective, actually. So it's important to keep that, but still, this made our life much easier. And during the COVID pandemic, it was very important for us because our patient couldn't go to the hospital. The hospital shut down. They couldn't go to the hospital to get their treatment. So we reached out to them and we managed to actually provide the medicine to all our patients. And this happened because the patients were connected. It wouldn't have been possible without it. So there is no doubt that the technology is there, but today the healthcare system is way behind on the digital revolution. You know, you can see your bank account on your mobile phone. You can't have your medical file. I don't know why.
Yes, and healthcare has been an industry that is behind the curve. Now, Joseph, in 2023, 2024, what are your plans for Axios in the Southeast Asian region?
Yes, in Southeast Asia, we intend to continue growing, getting more patients, digitalizing more that space, because we still have some resistance in some countries from different stakeholders. You know, I really feel that Malaysia is a star from that angle because their adoption to the new technology and to the innovation is very has been really very helpful. But that's the idea, and to really get everybody connected in that space that I call outside the hospital, which is. And it's not to replace the hospital, it's to complement the hospital. I mean, doctors and the hospitals are already overwhelmed. So the idea is to ease that pressure on them by providing services outside the hospital that could complement their services and reduce their burden. That's at least our vision in Southeast Asia.
Dr. Joseph, it's been a fascinating conversation. I really enjoyed this and I learned a lot as well. But before we leave, any final thoughts you'd like to leave the audience with?
You know, I feel that healthcare is the most important thing that we all have. And today the vision is no healthcare, it's the hospital and the community. And it's not my problem. Healthcare is our problem, the way climate change is our problem. You know, you can't keep it just to the healthcare professionals and to the experts. Everybody needs to feel involved and participate in transforming healthcare and bringing the healthcare into that 21st century with the digital revolution. I really think that this is where we need to be, and people feel that yes, this is where what we need to do.
Dr. Joseph, thank you very much for taking your time to be on the show.
Thank you very much. Thank you.
Now, we've been speaking to Dr. Joseph Saba. He's the CEO of Axios International. I'm Brian Fernandez, and we've been watching and listening to the BizTech Health and Wellness Show. This interview will be on our website, www.biztech.asia, as well as our syndication partners, TV stations, radio stations, and websites. Thanks a lot for tuning in.